Hey there everyone, Naveen Nathan, Assistant Professor of Anesthesiology at Northwestern University. We're going to start a series on regional and orthopedic anesthesia for the Part 2 advanced exam, ABA advanced exam. Unlike the Part 1 basic exam where your primary focus was on neuraxial anesthesia, although there will be a little bit of that at the end, this series really covers peripheral nerve blockade, and that's really where you should focus more of your attention. So we're going to begin with upper extremity nerve blocks. In this module, we're going to talk about the brachial plexus and specifically the interscaling nerve block. So which fibers constitute the brachial plexus? You should definitely know this. This is from C5 to T1. And oftentimes there's variability here. You can get contributions from C4 or T2. C4 contributes 2/3 of the time, and T2 contributes 1/3 of the time. Okay, so again, C5 to C8 are the fibers that constitute the brachial plexus, including T1, and C4, 67% of the time, contributes as well. T2 contributes 33% of the time. And then, of course, you should recall your categorizations of the nerve anatomy, which includes the roots, cervical nerve roots, which converge on the trunks and then divide into divisions, reconverge onto cords, and then end in terminal branches. Definitely review the dermatomal spread of these nerve roots, and as you can see from C5 all the way to T1, they sort of spiral around the upper extremity such that T1 comes up to meet with T5 on the volar aspect of the arm. And this is what we've been talking about, of course, the roots that come out of the spinal foramina, which converge on these trunks, the superior, middle, and inferior trunks, which then split off into anterior and posterior divisions under the clavicle, and then reconverge onto the cords, the lateral cord, posterior cord, and medial cord, and then ultimately redistribute down into terminal branches, the axillary nerve, musculocutaneous, median, radial, and ulnar nerves. So in addition to the dermatomal distribution of these nerve roots, you also have to know how the peripheral nerves terminate, okay? Especially the musculocutaneous, which is the lateral aspect of the forearm, the radial nerve, which you see just in slight blue coloration here, but most of it is on the posterior aspect of the hand, okay, in the forearm. The median nerve here, the ulnar nerve on the medial aspect, the medial 1.5 digits here. Okay, and the medial antebrachial cutaneous nerve. So the brachial plexus is enveloped by the posterior fascia of the anterior scalene muscle and the anterior fascia of the middle scalene muscle, so-called interscalene space. So it's sandwiched right in between the anterior and middle scalenes. The principal indication for interscaling block is, of course, surgery on the shoulder. No other upper extremity block can capture the shoulder's innervation, so that's why this interscaling block is indicated for those types of procedures. Anything distal to the shoulder, and you can start working your way down the brachial plexus and do supraclavicular blocks, infraclavicular blocks, or even axillary blocks. And so here we see the brachial plexus sandwiched in between the middle scalene here and the anterior scalene. And there's a variety of effects that occur when you block the brachial plexus at this level, which we'll get to. And the other relevant muscles are the strap muscles, the longus capitis and longus coli, as well as the splenius capitis posteriorly. So if you're performing an interscaling technique blind, what cervical level is the interscaling block performed at, and what anatomic structures in the neck identify this level? Okay, so most of you are probably used to using ultrasound guidance for your interscaling block, and it may not occur to you that you could do this technique blind. That's how the technique was developed, and it was done at the level of C6. And you would identify that by identifying the cricoid cartilage and working your way laterally from that, and that's how you do that. Your fingers would often fall into what's called the interscaling groove at that level. So the patient lies supine with their head turned slightly towards the contralateral side. The interscaling groove, as I said, the groove between the anterior and middle scalene, is palpated posterior to the sternocleidomastoid muscle. And that's at the level of C6, which drops a line laterally from the cricoid cartilage. The external jugular vein typically crosses the interscaling groove at C6, but there's a high degree of variability with that. And that's exactly what you see in this image from Miller's anesthesia. Here, the anesthesiologist's fingers are falling into that interscaling groove between the anterior and middle scalene muscle. And it does help to have the patient's head turned because, as you know, the sternocleidomastoid on the opposite side is what actually contracts to make that happen. So that way you readily identify the posterior border of the sternocleidomastoid, and you don't get that confused with part of the interscaling groove. Now, most of us are used to using ultrasound to perform these blocks, and what you see here is the sternocleidomastoid medially, and this is the posterior aspect of the patient. This is the anterior scalene muscle and the middle scalene muscle, and you have the cervical nerve roots coming through, sandwiched in between these two scalene muscles, and that's your brachial plexus. So if you're not particularly adept at reading ultrasound images, definitely go over this. The NYSORA website, the New York School of Regional Anesthesia website, is an excellent resource to review regional anesthesia techniques. They have lots of ultrasound images as well, and they thoroughly explain these blocks. Definitely worth your time, your investment of time to go through that. So during interscaling block with nerve stimulation, the patient's diaphragm begins to contract. How should the needle be redirected? Your choices are anterior, posterior, caudad, or cephalad. So if the patient is starting to have hiccups, you're probably placing your needle a little too anteriorly, because that's where the phrenic nerve lives. It courses down anteriorly relative to the brachial plexus. So you would need to move your needle posteriorly. And that's exactly what this slide explains. If you redirect it too posteriorly, you can be in the territory of the accessory nerve, in which case the trapezius muscle will start to contract. You'll get sort of a shoulder shrug sort of movement of the patient. And that's how you know you're way too posterior. Now, what percent of the time does the interscaling block capture the phrenic nerve? It's pretty much 100% of the time. Okay. The better question is, what percent decrement in pulmonary function is seen with hemidiaphragmatic paralysis? 5%, 10%, 25%, or 33%? The correct answer here is a 25% reduction in pulmonary function. Okay. So you typically see about a 25% reduction in vital capacity in the average healthy patient due to hemidiaphragmatic paralysis that occurs with the interscaling block. That's been tested multiple times on the ABA exam, so definitely remember that. So ipsilateral phrenic block is largely unavoidable with the interscaling block. You can try and minimize the effect by using lower volumes and lower doses of interscaling local anesthetic, but it's not a reliable, 100% reliable methodology for avoiding phrenic blockade. If you really want to do that, you have to work your way down to distal brachial plexus blocks. Of course, if you're trying to anesthetize a shoulder, you really have very few other options. What peripheral upper extremity nerve is often missed with the interscaling, and how would you test for it? So remember, where you're injecting, you're giving local anesthetic in the interscaling groove, and it's the lowest nerve roots, okay, C8 level, T1 level, where the local anesthetic has the hardest time penetrating. And those roots tend to converge on the ulnar nerve. So the ulnar nerve is oftentimes missed with the interscaling for that reason. You test for it by assessing sensation on the medial aspect, the medial 1.5 digits of that extremity being blocked, and assess for sensory deficits there. You can also do abduction against resistance of the digits as well for the motor function of the ulnar nerve. So overall, you get variable blockade of the lower trunk, that is the ulnar nerve as we described, even with larger volumes of injection. Digital pressure above the injection site and downward massage may facilitate caudad spread and blockade of the lower trunk, but it's not a fully reliable way to do that. You may have to reinstitute the block. And as I mentioned earlier, it's the medial aspect of the upper extremity that gets missed if you miss the ulnar nerve. As you can see, that does correspond to C8 and T1. So there's a lot of other nerves in the territory of the interscalene groove. You can anesthetize the vagus nerve and the recurrent laryngeal and cervical sympathetic nerves. And the patients may exhibit a variety of symptoms related to this. They can develop hoarseness, Horner syndrome, droopy eyelid, droopy face. These all resolve spontaneously after several hours. The incidence of pneumothorax is pretty low with correct needle placement at the C5 or C6 level. You're quite far away from the dome of the pleura. It's not usually a significant problem. You can get severe hypotension bradycardia. Interestingly, this so-called Beazell-Jarisch reflex. It's been reported in awake, sitting patients undergoing shoulder surgery under interscaling block. The cause isn't well elucidated, but it's presumed to be stimulation of the intracardiac mechanoreceptors by decreased venous return, producing an abrupt withdrawal of sympathetic tone and enhanced parasympathetic output. Remember, you're doing brachial interscaling blocks for shoulder surgery, and shoulder surgery is oftentimes done in the beach chair position. And so when you do this block and then begin sedation or even general anesthesia for these patients, and then put them in beach chair position, you get a lot of venous pooling and loss of preload. So the combination of all these things may result in right-sided hypotension, right-sided hypovolemia, which basically induces a vagotonic response to slow the heart rate down so that it can increase filling. So you may see this reflex. The frequency of this reflex is decreased when prophylactic beta blockers are administered, which is a little ironic. So no one's ever perfectly explained why this may occur, but if you look this up, using beta blockers may actually decrease the chance of this reflex occurring. So what adjuncts to the interscaling block are likely to be effective in increased analgesia, and what would be better to give to this end, gabapentin or dexamethasone? Now, it's long been understood that dexamethasone does prove beneficial in enhancing, augmenting the density of the block and prolonging its duration to some degree. Okay. Gabapentin doesn't really do much when you add it to ropivacaine or bupivacaine. So it's not typically used as an augmented anesthetic agent for the purposes of upper extremity analgesia. Dexamethasone, adding upwards of 8 milligrams, can more than double the analgesic effect. So it's a nice way to get some mileage out of your block without having to use more local anesthetic burden. Okay. Interestingly, they've added things like midazolam for upper extremity nerve block, and it provided a more rapid onset of sensory motor block and extended the duration. So that covers the interscaling block. In the subsequent sections, we're going to move on to other upper extremity blocks and then lower extremity blocks as well.